A very good afternoon to everybody. This is Ripona presenting on behalf of Child in Need Institute. Today, I will be talking about a community-based convergent approach we followed in three districts of West Bengal in ensuring adequate nutrition among mothers during pregnancy. I have with me Dr. Nagma Nigar Shah and Dr. Ipshita Bhattacharya. Together, we work in the Health and Nutrition Division of CINI. I am associated as the Senior Manager of Health and Nutrition, and Dr. Shah and Dr. Bhattacharya take care of the monitoring and evaluation sections. To start with, we all know that the country today has a high prevalence of anemia among women, stunting among children is on the rise, and low BMI is common among adolescents and women. All these calls for a definitive attention to work on issues of maternal nutrition. A study conducted in early 2018 in three diversified districts of West Bengal also revealed similar findings. Stunting was at 48% and anemia among pregnant women was as high as 74%. Hence, STINI started this intervention focused on ensuring essential health and nutrition services during the critical 1,000-day period. The cohort we worked with comprised of 472 pregnant women identified from 74 sub-health centers and spanning across 183 ICDS centers. These women were followed up from their first trimester till childbirth through a set of pre-designed intervention. The focus remained on assessing nutritional vulnerabilities and ensure appropriate follow-up through the frontline workers, ANM, ASHA and Anganwadi worker. 5 primary strategies were followed in the field to ensure a positive pregnancy outcome. First, it was ensured that to understand the nutritional status of the pregnant women, BMI of the woman was measured at the subcenter during pregnancy registration, and subsequently a monthly weight monitoring was done at the ICDS center in order to ensure appropriate weight gain. Both the practices were not prevalent in the state guidelines of ANC services. Second, ICDS centers in West Bengal provide hot cooked meal to its beneficiaries. But women take this back home and often the meal gets divided among larger family, especially children. To change the practice, spot feeding was endorsed at the ICDS centers, followed by spot intake of IFA tablets. This ensured supervised feeding along with additional time for the Anganwadi worker for counseling of the mothers. We all know that families have a big role in ensuring physical and emotional support during pregnancy. Hence, additional and joint home visits of ASHAs and Anganwadi workers were introduced to do family counseling. To increase service uptake, coupons were distributed to mothers for timely access of ANC services. Mothers collecting the highest number of coupons were provided with token rewards of appreciation at the end of pregnancy. Finally, convergence formed the key to the fifth strategy. It consisted of a round of simulation games conducted with the AAAs. The games focused on team building, communication and coordination, conducted in 3 rounds that highlighted the role each stakeholder should play in ensuring a healthy pregnancy. So, the entire field interventions revolved around activities promoting towards these 5 strategies. Coming to results, the gestational weight gain data of the 472 women we worked with was compared to the block data on gestational weight gain prior to the intervention. It showed that if you look at graph 1, average weight gain of intervention group was 9 kg as compared to block average of 7.68 kgs. In graph 2, percentage of women gaining above 10 kg was also 44% in intervention group compared to 25% of the comparison group. We also did a BMI-wise weight gain analysis which revealed that the severe thin and the thin had the highest spot of gain. This was also because a differential weight gain target was followed in the field for the overweight and obese women as per IOM guidelines. However, much detailed work is required on management of maternal obesity in a community setting. Looking at graph 4, Anemia was reduced by 10% at the end of the intervention, and in graph 5, percentage of LBWs were little lesser in the intervention group. Coming to policies, as I was saying, assessing nutrition risk and doing BMI is currently not a part of ANC package for pregnant women in West Bengal. So there lies the scope to incorporate the same and get integrated in the A&M training curriculums. Unless the nutrition risk category gets identified, it becomes difficult to take the consecutive steps thereafter. Currently in West Bengal, from the pilot in 3 blocks, the intervention is upscaled to 46 blocks, and this assessment process has been initiated with consent of Health Department. There is a need to mainstream monthly weight monitoring of pregnant women at ICTS. The platform of Poshan Divas can be used for the purpose, which is already existent. And finally, we know that maternal nutrition calls for a convergent action of multiple departments. Hence, ICDS and health should come forward and issue joint guidelines, develop operational training manuals, and promote maternal nutrition as a priority.